I'd like to begin by acknowledging the traditional owners of the lands on which I join you today, the Wurundjeri people of the Kulin Nations, and I'd like to pay my respects to elders past and present. Welcome to week 6 of HEA 10002. This week we cover quite a broad range of topics. In this video and the one to immediately follow, we look at the social causes of health and disease, examining pathology and health inequity through a sociological lens. We then move on to the examination of sanitation and introduce the concept of environmental determinants of health. So let's begin by looking at how the social determinants have a direct causal effect on disease and illness. When we take a sociological view of health, we are asserting that the social determinants of health have a direct causal effect, or, put another way, social factors are integral to discussions of pathology. Why is this a radical or controversial idea? Well, social factors, the determinants we introduced last week, things like the social gradient, your living conditions, your sexuality, your gender, these are not pathogens. They are not cancer cells, they are not an identifiable blocked artery. But when we say social causes of diseases, we are saying that these factors are causal. We are saying that assigning causation to biological factors alone just doesn't cut it. We saw this in week 2 in our BAME article. If you recall, this article spoke about the biological and social determinants of increased COVID-19 risk and COVID-19 related death among Black, Asian, and minority ethnic communities. It offered some potential biological reasons for the higher proportion of COVID-19 rates of death in this community. If you recall, these factors included things such as vitamin D deficiency and lower lung functioning. But ultimately, this level of analysis was insufficient to account for the discrepancy. It was the social factors that were increasing risk of exposure to COVID-19. Things like overcrowded housing, less capacity to work from home, higher risk in the workplace, less buying power to stockpile goods, meaning more frequent exposure to being out in public and public transport, etc. So what we're saying is that the social factors can initiate the onset of pathology. They lead to the exposure to the pathogen and therefore serve as a direct cause for disease. Some examples beyond COVID-19 appear in your lecture slides. For example, cholera. There is a well-known link between sanitation and the biological agent or bacteria for cholera. If you live in poverty, you may not have access to adequate sanitation, meaning you are at increased risk of exposure. Indeed, this is an almost perfect parallel to COVID-19 with our current practices and emphasis on hand washing, use of hand sanitizer, etc. Vaccines are another example of the social causes of disease. They buffer against a multitude of disease, but if you don't know they exist, if you don't know how to navigate the healthcare system to access them, or if you can't afford the out-of-pocket costs to get them, then you won't be vaccinated. This slide speaks about the shift in risk demographic when it comes to HIV/AIDS in America. Initially, HIV/AIDS was a disease of the affluent white gay male community, though after the identification of prevention strategies, the demographic of this disease shifted. The educated white gay male cohort were quick to adopt health promotion strategies. They could purchase condoms, they could engage in discussions around safer sex practices, and people could assert what they wanted in terms of safety. The population that this disease predominantly affected then shifted toward lower SES groups, African American and Hispanic gay men in the USA. Why was this the case? The reason offered on screen pertains to segregation. Higher levels of segregation mean that the risk of infection within this community or within this cohort will be higher than across or between groups. But also, other reasons not listed on screen include, for instance, having less power to negotiate safe sex practices and being forced into riskier situations in order to survive. This last point is relevant to discussions of trans women and HIV/AIDS. The incidence of HIV/AIDS among trans women of colour is recognised as a current public health crisis in America. And a lot of research suggests that because of social exclusion, trans women of colour who want to have sex with gay men often feel obliged to engage in risky sex, meaning sex without condoms, in order to make it better for their cisgender male partners. Because as trans research indicates over and over again, dating as a binary identified trans woman is really difficult. There is this damaging societal narrative that trans women are not real women, that places a burden on interpersonal sexual relationships that is causal to elevated HIV risk among trans women, and particularly trans women of colour. The next few slides present a further two case examples, smoking and diabetes. Regarding smoking, we know that tar is causal to smoking-related disease, but of course it has to get into the body. And the act of smoking, as research demonstrates, is not random. It is inherently social. We can see this when we look at reasons as to why people smoke. Almost all smokers report a dislike for smoking when they first start. But why do they persist? Well, often it is a shared behaviour or a collective behaviour. It's often related to fitting in. And as we would expect, when you no longer have a social group that supports the habit, people are more likely to cease smoking. What about diabetes? It's interesting that this data is relating to USA research, though the same pattern can be found in Australia among our Aboriginal and Torres Strait Islander communities. There is an inextricable link between race, income, and diabetes. Firstly, race is a determinant of affluence in the USA. The more money you have, the more choices you have in terms of education, lifestyle, and access to food and the types of foods that you can purchase. So affluence, which is greatly linked to race, enables access to the list of health protective factors that appear on the left side of this table, whereas being lower on the social gradient, which is also linked to race, means you're exposed to a range of health risk factors for diabetes that appear on the right side of this table. On screen is a question that we will be discussing in our next class. Now is a great time to jot down your ideas on this topic. The question relates to how you might improve nutrition for children in a low-income community. This concludes video 1. Up next, we will consider the specific social and health experiences of Aboriginal and Torres Strait Islander Australians.